Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
All right, what's up, everybody? This is Erin Falls, one of the doctors at Wild Health. Super stoked to be with Dr. Nathan Bryan today. Dr. Nathan Bryan is a pioneering scientist, entrepreneur, and leading authority on nitric oxide. With over 100 peer-reviewed publications and dozens of patents, his research has reshaped the way we think about health, performance, and longevity. He's a former professor of molecular medicine. Dr. Bryan left academia to bring science-backed solutions directly to the public. He's challenging misinformation and driving innovation in a billion-dollar industry. He's the author of The Secret of Nitric Oxide, Bringing the Science to Life, and his work continues to impact countless lives worldwide. I'm really excited about this conversation. I selfishly feel like I'll learn a lot. I think at first glance, some of our listeners may not quite know if this is pertinent to them, but I think it will be pertinent to just about everybody. So hang with us. As you'll soon learn, nitric oxide is foundational for, the health of pretty much every process in our body, it sounds like. But the lack thereof or poor functioning of can have pretty disastrous consequences for a lot of the diseases that probably have had a really close touch on most people's lives in one way or another. So really excited to learn more. If you wouldn't mind just giving the quick elevator pitch of like why this matters to you, just in case people are curious, like why do I need to know about nitric oxide? Why do you think this is so foundational for medicine, for health, for humanity?
Yeah. Well, thanks, Aaron. It's great to be with you. Thanks for having me on. Now, look, nitric oxide is, as you said, a foundational molecule. It's a naturally occurring signaling molecule, so it's naturally produced in the body. Interestingly, it's a gas, and once it's produced, it's gone in less than a second. That second or so it's around, it activates second messenger systems and then just starts this entire cascade of very important signaling transduction pathways. So it's primarily recognized as a vasodilator. So when it's produced, it relaxes the smooth muscle that surrounds blood vessels and leads to blood vessel relaxation or dilation. Then that improves blood flow, circulation, oxygen delivery. But it's a neurotransmitter in the central nervous system. It's how our immune cells kill off bacteria, viruses, and pathogens. It's the signal that tells our own stem cells to mobilize and differentiate. So it's extremely important in regenerative medicine. It activates mitochondrial and improves the efficiency of ATP production or energy production within the cell. And it prevents our telomeres from getting shorter. So everything we know about health, longevity, and human optimization, and really disease prevention, can be tied back to adequate production of nitric oxide.
And there's an involvement with blood sugar as well, correct?
Absolutely. We've known for...
I'm just trying to tie in all of our Wild Health listeners because you've hit a lot of the topics that really excite them. And I just think there's one more. There's probably more than that.
Well, no, I mean, look, we all know the statistics. 9 out of 10 Americans are metabolically unfit. And so we know that people, specifically get type 2 diabetes, have much higher incidence of heart attack, stroke, all cardiovascular related morbidity and mortality. And so we started investigating, how does nitric oxide play a role in insulin signaling and glucose uptake in metabolic disease? And what we found, we published on this in 2011, that the ability of the cell to produce nitric oxide is part of the insulin signaling pathway. So when insulin is secreted by the pancreas, it binds to the insulin receptors, then that starts an intracellular cascade that really depends upon that cell's ability to produce nitric oxide. And then when nitric oxide is produced, it activates GLUT4, which is a primary cytosolic protein that then goes to the membrane and brings glucose into the cell. So that's how insulin works. Activates intracellular signaling, translocates GLUT4, and you bring glucose into the cell, clear it from the circulation. But what we discovered is that if the cell cannot make nitric oxide, if the nitric oxide synthase enzyme isn't functional, then you get insulin resistance and you don't get GLUT4 translocation and you don't clear glucose from the circulation. So what we're finding is insulin resistance in type 2 diabetes is a symptom of nitric oxide deficiency.
And I know we'll talk about this later, but I've also heard you speak on the other end of that spectrum, meaning when blood sugar is too high, this further disrupts nitric oxide, right? So it's a little bit of a catch-22 there.
No, it's a
So
feed forward mechanism, and it's a perpetual cycle
such a bummer.
yeah. Now, because what happens is once you get elevated blood sugar, glucose is sticky. As the name implies, it's glue, right? So it sticks to things. It sticks to hemoglobin, and we can measure that as hemoglobin A1C. But it also sticks to the enzyme nitric oxide synthase. And so it glues this enzyme together and many other enzymes for that matter, and locks it into a conformation where it can't transfer electrons and it can't do its job. So again, until we start to interrupt this vicious cycle, and that's why people with metabolic disease have poor healing wounds. They have macular degeneration. They have neuropathy, retinopathy. It's because of the excess sugar and the lack of nitric oxide production.
Super fascinating. Thank you for that overview. I think hopefully we caught a lot of people's attention.
And I think the other
Between
important thing is I think if you look at the primary therapeutic regimen for diabetes in metformin and glucophage, right? That drug activates another signaling molecule called AMP kinase. And then again, part of that signaling is to activate nitric oxide production to increase GLUT4 translocation. So metformin is a very effective drug, but we have to first focus on restoring the function of the enzyme in order to potentiate the therapeutic effects of that drug therapy. So again,
yeah,
everything
it's a
kind of
moot
revolves
point.
around the adequate production of nitric oxide.
Super interesting. So what got you so excited about this? You've been in this field for decades now, studying this, right? Is there a personal reason for that for you? Did you just kind of happen into it in your clinical training? Give us a little bit of background now that you've hopefully hooked some people on the relevance here.
I got into this field in the late 90s, early 2000s. I had a degree in biochemistry from the University of Texas as an undergrad, and then I went to LSU School of Medicine, and I was working on a PhD in molecular and cellular physiology. And a Nobel Prize had just been awarded in 1998 for the discovery of nitric oxide. And, fortunately, Lou Ignarro, one of the scientists who shared the Nobel Prize, came to LSU School of Medicine and gave a lecture and had a chance to interact with him and have dinner with him and really just ask a lot of questions. And he told me back then that he goes, Ethan, if we can figure out how to restore or develop therapeutics that could restore the production of nitric oxide or lead to nitric oxide signaling, it would change the world and it would change the landscape of medicine and how we treat patients. And so that was the challenge. And, so my PhD was on trying to develop analytical methods that we could detect nitric oxide in biological systems. How do we detect this fleeting gas at nanomolar or femtomolar concentrations? And then how do we create a fingerprint of endobiology in different diseases from diabetes, heart disease, Alzheimer's, autoimmune disease? And that required obviously certain analytical methods and an understanding of the biochemistry of once nitric oxide is produced, where does it go, what does it become, and what does it do? And so, I solved that riddle in about 2.5 years, finished my PhD in about less than 3 years. And then, I went and trained at Boston, the Boston Medical Center, and in the Whitaker Cardiovascular Institute, still trying to understand the effects of nitric oxide in vascular biology and cardiology. Um, and then after a 2-year fellowship, I was recruited by Fred Murad, one of the other guys who shared the Nobel Prize, and my first faculty position in molecular medicine at UT Medical School in Houston. And it was there that we just continued to try to, figure out how to make nitric oxide. How does the human body make it? What leads to a loss of nitric oxide production? And then once we had a clear understanding of that, then we could start developing rational therapies and product technology that address the root cause of nitric oxide deficiency. And so that's what I've done for the past almost 30 years now.
Cool. And I read something somewhere about was there something with your father, a personal anecdote that kind of took this home for you, or corrects me if I'm wrong on any of this.
No, you're spot on. I mean, my dad's, had a car accident in 1984. and he had T11 compression injury, left him
Mm,
paralyzed from the mid back down. And so, I
I'm
watched
sorry.
even as a kid and even as an adult and student and then professional, the standard of care failed my dad. A paraplegic, diabetic, elderly person with uncontrolled hypertension, resistant hypertension, diabetes, non-healing wounds, decubitus ulcers, developing osteonecrosis, osteomyelitis, sepsis, and watching him almost die from an infected wound multiple times. And the wound care docs I'd take him to, and the physicians would, really didn't have any answers. They go, "Well, you'll probably never heal this wound because of his paraplegia, diabetes, high blood pressure, just all the comorbidities." And I just refused to accept that. And so, he's in the hospital on IV antibiotics, almost died from sepsis from an infected wound. And I just said, "Look, we got to heal this." I started employing these nitric oxide technologies. I would, do a wet to dry wound care on him twice a day, put a nitric oxide releasing gauze into the wound bed. And remarkably, within probably less than a week, we started to see tissue granulation. We killed the infection. The wound started to heal.
Wow.
And we took a 4-year-old non-healing stage 4 diabetic ulcer and healed it in less than a year just with nitric oxide. And we got him off prescription medication for his high blood pressure. We managed his diabetes. And for me, when I witnessed that of the power of nitric oxide in a elderly paraplegic diabetic patient, I knew, wow, this is really powerful what we're doing. So that's really been a driving motivation to me because the standard of care failed my dad and it fails many patients.
Yeah, I expect that, especially for our listening panel, these chronic non-healing wounds are maybe something a lot of people haven't been around. But gosh, this is accepted as just futile in the medical field, like what was shared with you. It's that is accepted as the standard of care typically.
Yeah, and the
When there
standard
are
of care.
that many comorbidities, we see these in the hospital all the time. This is something that is unfortunately all too common and absolutely miserable for people to experience. And so I think that's I mean personally I think that's such an incredible story. And your dad was so lucky to have you as an advocate. And what a powerful reminder that we shouldn't just be accepting the standard. We should stay curious and we should stay you know, able to advocate for ourselves and our loved ones. I think a lot of people that come to a field of medicine like what we practice at Wild Health have that in them, because they're curious. Is there a better way of doing things? Both physicians that come to practice this way and patients alike, honestly. So thank you for sharing the personal piece of it for you. Um, we dove in just to a touch of the medical use of nitric oxide there. And I will tell you, I mentioned this to Dr. Bryan before we started recording, but in another life, I practiced hospital medicine and there was a good amount of critical care work involved there. And we use nitric oxide pretty regularly. And I got to thinking, I was reading about nitric oxide, preparing for this interview, and the Nobel Peace Prize was awarded in what was it, 1998, like not
Yeah,
very
the
long
Nobel Prize in
ago
Medicine. Yeah.
for the I don't know the exact reason, but it was for recognizing its use in this aspect, right? Essentially.
Yeah, it was the Nobel
Um,
Prize in Physiology or Medicine for nitric oxide as a signaling molecule in the cardiovascular system. So that was
got
the
it.
basis for the prize. Yeah.
But like, for how long have we been using nitric oxide as signaling molecules in the cardiovascular system? I mean, how long have we been using, nitric oxide for chest pain, as an example? Let alone the other implications. I mean, we use it in critical care for other things, for respiratory distress syndrome and numerous things that can have some pretty radical outcomes, actually. A lot of that is newer, but for the cardiovascular system, has it not been used much longer than what we knew we were doing?
Now, for hundreds of years, in fact, I mean,
That's
drugs
what
like
I thought.
nitroglycerin.
I was like,
Yeah,
am I using it?
yeah.
Okay.
No, hundreds of years. But so nitroglycerin for the treatment of acute angina or obstructive coronary disease. Those drugs were used in the days of Alfred Nobel, who invented dynamite, and it was paradox or prescribed nitroglycerin for heart disease. But it wasn't so hundred years ago. Those physicians used that drug because they knew it worked. but they didn't
Hmm.
understand mechanistically how that's worked. And that was really the work
Right.
of Fred Murad, who discovered that nitroglycerin works because it's metabolized into nitric oxide gas and then it dilates the blood vessels. And so then, even in the late 80s, early 90s, it was administered acutely for premature babies with pulmonary hypertension. And this was work done at Mass General and Harvard Medical School by Warren Zapaw. And, that's saved millions of babies' lives. And, that's really the only FDA-approved indication for inhalative nitric oxide therapy is neonates with pulmonary hypertension.
Pulmonary
But as
hypertension,
you know, as
which
a hospitalist in critical care, you can use it for pulmonary hypertension in adults. You can use it for cardiopulmonary bypass or to improve blood oxygen
ARDS.
saturation in ARDS for asthma. Because it's a vasodilator, but it's also a bronchodilator. It relaxes the smooth muscle of the bronchioles and can improve airway and match ventilation to perfusion and overcome a lot of these, respiratory diseases and COPD and asthma and emphysema.
Yeah, yeah. And with certain heart failure patients too, just like reducing that load that the heart is pressing
Absolutely.
against essentially. Like whatever load you're trying to reduce, I suppose, in the body. Very cool. So I would love to give an overview of what are the most common things you see when there's a problem with nitric oxide. And I'm curious about this because I assume this can come from multiple angles. We check NOS SNPs
Yeah.
for our patients, nitric oxide synthetase or
Synthase.
synthase?
That's right.
Synthase, excuse me. And multiple other genetic SNPs that I presume could be related here. So I assume there's some people that just inherently, maybe could use some support here. And then I assume there's other things we do probably more importantly that can deplete this compound for us. And then there's probably some other angles as well. So I'd be curious, like, what are you seeing as the endpoints here for people? And then what can we do about it, right? Like, how do you commonly see this manifest clinically? Like, why should this matter to people? Let's start there.
Yeah, well, it's a very important question because it's not a lab. Certainly you can run genetics and look at predispositions and SNPs on certain gene, uh, but we have to rely on symptoms. And so what we've seen is through the course of the past 20 30 years that when you start to gradually lose the ability to produce nitric oxide, there's a hierarchy of symptoms. And the first one to manifest is typically erectile dysfunction. And that makes sense, right? Because if you can't dilate the blood vessels of the sex organs, you can't get an erection. So an erection is an increase in blood flow or engorgement. And that's dependent upon the sex organ's ability to produce nitric oxide to dilate the blood vessels to allow for the accommodation of more blood flow. And we know 50% of the men over the age of 40 self-report ED. And it's not just a male problem. The same thing happens in women, right? Because women get erections, clitoral erections, labial engorgement. In fact, for an orgasm to occur, when you understand the hemodynamics of female orgasm, it manifests or climaxes when there's an increase in intralabial, interclitoral pressures. Well, that pressure comes from an increase in blood flow. That blood flow comes from the production of nitric oxide. You can't make nitric oxide, no blood flow, no increase in pressures, and women become anorgasmic or develop a wide range of what's called female sexual arousal disorder. So that's first, ED. Then what happens, if not corrected, you start to develop high blood pressure, right? Because we have a finite volume of blood pumping through our blood vessels. And if we can make nitric oxide, we're dilating, we're allowing for that expansion and increased compliance with each heartbeat. But if we can't make nitric oxide, then the blood vessels become chronically constricted. And now we've got that same volume of blood pumping through smaller pipes, and simple physics tells us that pressure increases. So 2 out of 3 Americans have an unsafe elevation in blood pressure. Then number 3, as we talked about, you start to develop metabolic disease and insulin resistance because if you can't transduce that extracellular signal intracellularly to produce nitric oxide and clear glucose from the circulation, you develop metabolic disease. And then again, this is a progression. Then you start to develop exercise intolerance, short of breath, can't go up a flight of steps. And then 5th is we start to see mild cognitive impairment, dementia, and Alzheimer's. Because again, it's all about blood flow. Alzheimer's is a vascular disease, it's a metabolic disease, and nitric oxide is what regulates both of those, as we now know.
Super interesting. So it likely has a big impact on cardiovascular disease, metabolic
For sure.
disease, neurodegenerative disease, things like dementia, and I'm
Inflammation.
guessing cancers and inflammation as well. So kind of all the big horsemen that we know about
Okay.
in terms of chronic disease. So it's a player, a big one there.
For sure. With certainly Alzheimer's, cardiovascular disease, metabolic disease, cancer, based on the Warburg effect, and Otto Warburg, the Nobel Prize, you know, decades ago, we know that cancer only grows in a low pH, low oxygen, low voltage environment. And it's a metabolic disease and it's mitochondrial dysfunction. And so, again, nitric oxide oxygenates the tumor. Tumor only goes in a hypoxic environment, and tumors don't like oxygen. If we can recouple the electron transport chain of the mitochondria, then you change that entire Warburg effect and you create an environment where cancer cells can't grow and can't proliferate. So nitric oxide is extremely anti-cancer activity because it addresses the metabolic issues of cancer.
Is there any, when we speak about these sorts of chronic diseases, these probably have, like I mentioned before, a personal impact on most people listening because most of us either have experienced or know somebody who has experienced one of these diseases because they're pervasive, right, in our culture. Um, what research can you give us that you've looked at that is hopeful in regards to, nitric oxide and in optimizing some of these outcomes?
Yeah. Well, we've published a number of peer-reviewed, randomized, placebo-controlled clinical trials um, over the course of the last several years. In fact, we had a nitric oxide drug as an early treatment for COVID. But so here's what we know. We know that if we can deliver nitric oxide and recapitulate nitric oxide signaling, that we can see plaque regression in patients with carotid plaque and cardiovascular disease. And we start to see plaque regression and the blood vessels in the arteries start to clear up. We know that we can normalize blood pressure. We can reduce inflammation. One of my patents is on a method of reducing inflammation. We see about a 37% reduction in C-reactive protein in 30 days. We reduce triglycerides by about 30% in 30 days. We can increase the number of circulating stem cells and overcome and really the story I tell that's most prominent is a paper we published in 2011 in a pediatric patient we were treating at Texas Children's Hospital. He was a 15-year-old kid that suffered from a rare genetic disorder called arginosuccinic acid urea, which is a big word. We call it ASA, but it's a urea cycle disorder, and it's an inborn error in metabolism. And so this kid presented at 5 years of age with neurological delay. Genetic testing at the time, they found that it was an ASA disorder. And so they put him on drug therapy, triple antihypertensive therapy, and treated him for the hyperammonemia, which is the primary clinical presentation. But for 10 years, he developed severe hypertension. And in February of 2010, he came to Texas Children's Hospital, and his blood pressure was 210 over 115. And there was no prescription medication that these physicians were giving him that normalized his blood pressure. So he was critical. He was in the intensive care unit. And so they had approached me back in 2006 to try to help understand these collateral symptoms that couldn't be described by the underlying diagnosis. For instance, the resistant hypertension, the kidney disease, the neurological dysfunction that appeared to be independent of the recurrent hyperammonemia. He had blood clotting disorders. So when you just look at the genetic aspect of that patient, it didn't explain all these other symptoms. So then we modeled it in the lab, and we created mouse models of ASA deficiency or ASL deficiency, and we found that it was a nitric oxide problem. It was a nitric oxide deficiency. And now when you look at that patient through the lens of a nitric oxide perspective, that explained his hypertension. That explained his renal hypertension and his kidney disease. It explained the blood clotting disorders. So then at that time in 2010, they started treating him with isosorbide, similar to nitroglycerin, which can be metabolized into nitric oxide. And remarkably, within 4 days, his blood pressure completely normalized and got him off the beta blockers, the ACE inhibitors, the calcium channel blockers. And his blood pressure was pretty well normalized for, 3-4 months, but he developed tolerance, which is typical to organic nitrate therapy. And he was no longer responsive to the isosorbide or the Isodil. And so he came back to Texas Children's almost a year to the date later, and he was taking 20 milligrams Isodil 4 times a day, and his blood pressure was 180 over 110. So then we started dosing him with my lozenge, this nitric oxide releasing lozenge. And within 4 hours, his blood pressure completely normalized. 120, 125 over 80. And we got him off all prescription drugs. His kidney disease resolved within 5 days, no longer spilling protein in the urine. He had the heart twice the size of a normal 15-year-old, the severe left ventricular hypertrophy from pumping all those years over increased pressure. His heart developed heart disease and LVH. And within 5 months, his heart was completely normal. We remodeled the heart, we increased circulating stem cells, and 5 months later, he had the normal size, normal function of a very high-performing 15-year-old. And we improved his neurological function. He started beating his dad at chess. So every clinical aspect of a very rare genetic disorder, nitric oxide completely overcame that and fixed it. And we published
What a
this in the
special
American Journal
story.
of Human Genetics in 2011. And that right there, really opened my eyes. If nitric oxide can do this to an inborn error in metabolism, a genetic issue, and can completely overcome and fix the clinical symptoms and the metabolic disease and the vascular disease of a genetic disorder, think about what it could do in the general population and people who don't have these gene defects.
Yeah, I'm just thinking of so many potential clinical applications. My mind is just rolling right now, of things that, especially if you bring in the blood clotting aspect of it, you
Sure.
know, so many things in medicine are from poor perfusion at the end of the day, and poor blood flow at the end of the day. So this is just, I think, I'm assuming this is maybe part of what got you so excited about continuing this field. So
Yeah.
just kind of endless applications of how things could be improved.
Now you look, you hit the nail on the head. Every single chronic disease is characterized by decreased blood flow. Whether it's neurological disease, you can look at SPECT scans or functional MRIs of the brain. There's focal ischemia, hypoperfusion. Heart disease, again, it's ischemic, lack of blood flow, or COVID,
Mhm.
it's hypoxia, lack
Yeah,
of oxygen delivery.
COVID's kind of a clear.
Yeah.
I thought of preeclampsia when you and I were talking.
Now
When you mentioned
pre-eclampsia
that
study?
that
Yeah.
young boy, I was like, oh, check, check, check. This is a field that we don't know much about theoretically in medicine and or what to do about it. And it's a bit of a cluster in real life. I can
That's
attest
exactly right.
to.
When we
Um,
published that paper and for the ASA patient, the OB-GYNs, the high-risk OB-GYNs in the medical center go, "This is my preeclamptic patient." And so we did a very small clinical trial, I think in 10 patients that were admitted for preeclampsia. And we started dosing them with the lozenge, and we saw the blood pressure come down without an increase in intracranial pressures, which is a major problem in the hypertensive treatment of preeclamptic patients. And then we monitored through ultrasound the baby inside the womb, and seemed to be very well tolerated. So we could extend the gestation and prevent the early delivery of these babies in premature or in preeclamptic patients, and that's the goal. That should be the goal of any therapy because number one, you want to save the life of the mom, you want to save the life of the baby, and make sure that that baby comes out fully developed. And so this was a remarkable observation. We never really followed up on it. We never published it. It was preliminary. Um, but I think there's enormous promise and application in preeclampsia.
yeah, so cool. Um, Awesome. So I want to talk about what do we do about this because that's where my brain goes, and I think that's what really excites people. It can feel like heavy to learn about how much everything applies to why it's going bad. So I want to get there, but while we're still talking about the applications clinically and why this matters, let's dive just a little bit into the regenerative medicine, longevity realm, whatever you want to call it. It's a hot topic these days. And there's big applications here too, right? I mean, you mentioned telomere applications. You mentioned mitochondrial health. You mentioned stem cells. And just off the top of my head, these are things you've mentioned on this interview alone. So do you feel like this is a bit going to be a big application for nitric oxide soon or in the distant future? Or what are your thoughts here?
Now, I think it's foundational for regenerative medicine because of the things that we look at in terms of longevity. I mean, there's this whole emerging field of longevity. And I think the perspective is becoming to change because, as you know, medicine is a reactive practice, right? People don't make changes until there's an event, there's fear, they develop disease. But I think this whole, the biohacking, the longevity field, people are starting to think, how do we be proactive? Because I'm working to not get sick. I don't want to get sick and then have to work to get healthy. I'm going to work. I want to work to remain healthy. So when we look at longevity, there's three primary kind of what I think are objective endpoints that have really played themselves out in the scientific literature and the clinical literature. Number one are stem cells, right? So the older we get, it was once thought that the less stem cells we have, but now we know that there's stem cells in our adipose tissue. Certainly, bone marrow derived stem cells seem to decline over age, but it's the mobilization of stem cells that seem to be the rate limiting step in that. And in the 90s, it was published that nitric oxide is the signal that tells our own stem cells to mobilize and differentiate. So the older we get, typically the less nitric oxide we make, the less stem cells we have in circulation, so we don't repair and recover as well. And then if you look at mitochondria, as I mentioned, every single age-related chronic disease, lower numbers of mitochondria per cell, and the mitochondria are grossly inefficient. And so nitric oxide is what stimulates mitochondrial biogenesis and what recouples the electron transport chain to prevent electron leakage, and now you lead to more efficient ATP production with less oxygen. And then
Pretty
telomere,
important.
and the whole telomere biology, and again, a Nobel Prize awarded for the discovery of the telomerase enzyme. So the telomeres are the ends of the chromosomes that with each cellular replication, if you don't have an active telomerase enzyme, then these telomeres get shorter. And shorter telomeres, shorter lifespan. It's a very linear relationship. So if you can prevent telomere shortening, you can live a longer life. Longer telomeres, longer lifespan. And again, in the early 2000s, it was discovered that nitric oxide is the signal that turns gene expression of telomerase on and actually activates its function, stimulates its function. So nitric oxide is controlling the nuclear expression of telomerase enzyme, and it's controlling the enzymatic activity. So here's the clinical picture. If you can't make nitric oxide, you have mitochondrial dysfunction, you have shorter telomeres, and you have less stem cells in circulation. So you're on a very slippery slope to early demise, age-related chronic disease, and that's, in fact, most Americans. So we have to focus on maintaining adequate and sufficient nitric oxide production to prevent the rapid onset of disease and to prevent early death.
I'm just thinking there are multiple conditions, genetic and otherwise, where we know telomeres are shorter, right? I'm just
Progeria.
thinking of your case of that 15-year-old boy as an example. I mean, how many of these cases are we just looking at a little bit wrong? Like was that just associated with nitric oxide deficiency as well? I mean, obviously that benefited that boy immensely, but that wasn't even looked at for him, right? Initially. And I'm just kind of trying to like come at this with a beginner's mind with some other things I know about now, hearing all of these tie-ins, like, and what's interesting that keeps coming up in my mind is how much of this is causative versus like, is it just correlated with the nitric oxide deficiency? Either way, does it matter if you replete it and it gets better, right? So I'm you
No, I
making me
think
very
that's look, that's
curious
right. I
on
mean,
this call.
yeah. No, I think clinically, if people get better, then most clinicians, I think you're probably more curious and inquisitive than most clinicians because if something works, they really don't care how it works, right? They just know that it works. They want their patients to get better. So what I've done, I spent 25 years in academia, is understanding what are the clinical observations of how they present clinically and what makes them better, and then work backwards to try to figure out mechanism. Because once you figure out mechanism, you can make the entire thing work better. So yeah, the nitric oxide didn't fix this kid's genetic disorder, but it certainly addressed the clinical presentations of the consequence from that genetic disorder. And I think, when I was at UT Medical School in Houston as a professor at the Institute of Molecular Medicine, we started to see this because, our in Houston, as you know, the world's largest medical center, they're specialists in different disciplines. And so a cardiology colleague of mine, we thought, well, what if this pediatric doc is treating the same thing as an idiopathic cardiomyopathy, or the neurologist is treating a patient, and we're not looking at it through the proper lens because, cardiologist only looks at the heart, right? A neurologist is only looking at the brain. They don't put the pieces of the
Right.
puzzle together from
It's so
mechanism.
siloed.
And so we thought, well, let's focus all this and look through this through a single lens and not as a specialist, and then really address one, mitochondrial dysfunction, nitric oxide production, and then start to employ strategies to treat these patients differently and not through the single lens of a specialist.
Yeah. I was always told in training that I needed to focus more on one thing to get really good at it. And I'm told that sometimes in business too, like you can't market
Yeah.
everything at once and you can't sell everything at once. Like you have to focus in. But I'm going to keep my like curious, sporadic, widespread brain right now because I think for this kind of a field, it can have its benefits.
Well, I think
Um,
there is some benefit to that. I mean, obviously,
hun-
as a
100%.
scientist, I'm more interested in looking at the big picture. But as an entrepreneur, from a business standpoint, I do one thing, and I do it better than
That's
anybody in the world.
true.
If I do nitric oxide, and there are other people who do very important things, but we do one thing and we do it better than anybody else.
Yeah. Yeah. Right on. Very cool. So, if this is so common and touches so many outcomes of disease and aging, one, let's talk about that. Let's talk about aging, right? I know that there's good data that nitric oxide goes down with age, right? Is this inevitable? Is this innate, or is this something we have control over? Um, does it just go down with age, or do all these other disease processes go up? And so we don't create as much of it. Like, what are your thoughts there?
Now, look, certainly if you look at population-based studies, and this is in the published literature, that you see this age-related decline in nitric oxide production. Just taking samples of the general population, we see about 10 to 12% reduction per decade. Again, in the general population, starting in even the early 20s. So, by the time we're 40 or 50 years old, we have 50% of the nitric oxide we had when we were young. And now today, we know that this doesn't have to be the case. We can shift this curve to the left or to the right. So in order to understand this, number one, we had to figure out how does the human body make nitric oxide and what leads to this age-related decline. And so we focused on these two pathways, and they're completely independent. They're compensatory, but they're independent pathways. And so when we look at the function of the NOS enzyme, and we know what leads to NOS uncoupling. So the short answer is we can prevent this age-related decline, right? So I look at things like flow medium dilatation, endothelial function, vascular age, looking at markers of biological age, not just chronological age. So although I'm 51 years old, I have the vascular age of the nitric oxide production of a 36-year-old. And I was trying to reverse that clock even today. And then, we see people, 18, 21-year-old kids, who have the vascular age of a 60-year-old because of their metabolic disease, because of their sedentary lifestyle, because they're not moving, and because of all the junk food they're eating. So we
And
know
is
how to
that
shift
then
this.
reversible?
It is reversible. And certainly if you look at other relevant markers or objective markers of biological aging, we can see that we can move this. We can move this and prevent this age-related decline. So that's on the vascular production of nitric oxide. And then there's this pathway that's dependent upon the foods we eat, the bacteria in our mouth, and the ability to produce sufficient stomach acid. And that one is not age related. That one is based on your choices and your oral hygienic practices and what foods you decide to eat. And so now we know we certainly have the information and the knowledge to prevent the age related decline of vascular NO production, and we have the knowledge and information to optimize nitric oxide being produced by the foods we eat, by the presence of the bacteria in the mouth, and by maintaining adequate stomach acid production. And then we can maintain adequate systemic nitric oxide production throughout our lifetime.
Is that because you can then use if those things are not in the way, and I've heard you, I think, mention, I wanna say mouthwash,
Yeah,
fluoride, and, like, acid reducers as big
absolutely.
ones.
Those are the
Um,
big ones.
yeah, so if those aren't in the way as blocks, can we then appropriately use and activate nitric oxide from the foods we eat? Is that, in a
For sure.
nutshell, what okay.
Yeah, so this pathway is dependent upon, and, and it's pretty complex, but over the past 30 years, we've completely elucidated this pathway. So the mechanism of action of a plant-based diet, dietary approaches to stop hypertension, a Mediterranean diet, the Japanese diet, can be explained by nitric oxide. So these dietary patterns and food choices are enriched in nitrate, and it's inorganic nitrate. It's not organic nitrates like the drugs like nitroglycerin, but it's inorganic NO3 minus. And so when we consume these foods, it's taken up in the proximal gut and concentrated in our salivary glands. And this has been known since the 1970s. So then now, after 90 minutes after we consume green leafy vegetables, for example, then our saliva is secreting inorganic nitrate. And if we have the right oral bacteria and the healthy microbiome, these bacteria metabolize the nitrate into nitrite. Now, when we swallow our own saliva, that nitrite becomes nitric oxide in the lumen of the stomach. It's produced a burst of nitric oxide. It goes systemic. It binds to glutathione. It's transported as S-nitrosoglutathione. And that nitric oxide in the stomach kills H. pylori, the ulcer-causing bacteria. It can kill E. coli, botulism, Clostridium, any foodborne pathogen. It prevents ulcerations with chronic NSAID use. It enhances gastric mucosal blood flow to improve the absorption of basic nutrients and minerals. So that's a fundamental physiological pathway that, as we talked about, you completely block by using mouthwash to kill the good bacteria. It's completely blocked by using fluoride in your toothpaste, or 73% of the municipalities in the U.S. put fluoride in the drinking water because it's an antibacterial. And then really the big culprit are antacids, specifically the proton pump inhibitors. The omeprazole, pantoprazole, Prilosec, Prevacid of the world completely shut down nitric oxide production, both in the vascular endothelium and through this enterosalivary circuit. So if you want to completely inhibit nitric oxide production, take a PPI.
I work really closely with autoimmune disease, and have a history of autoimmunity myself, which is one of the reasons I did a deep dive into this field, in what I do now. And I'm just so curious right now why, if this may be why there's such a strong relationship with a massive rise in autoimmunity with the use of chronic PPIs.
No, I think it's completely explained by lack of stomach acid production. And it's not always just a nitric oxide problem. Because obviously you studied the gastroenterology, but in order to break down proteins, right, the human is never designed to assimilate foreign protein, whether it's plant protein or animal protein, from our diet. And the way this is supposed to work is we masticate the food, we break it down, and then when that goes into the stomach acid is required to break down proteins into the constituent amino acids. And then we absorb those amino acids and we make human proteins based on those amino acids. But if you can't make stomach acid, you can't break down proteins into amino acids. So what happens is you start to get these peptide fragments that are emptied into the duodenum. They go into the gut, and then you develop leaky gut. And these peptide fragments are absorbed across the epithelial cells. They go systemic. Your body sees it as a foreign antigen and attacks it and develops an autoimmunity against it.
Sure.
So if for me, mechanistically, biochemically, autoimmune disease is due to insufficient stomach acid production.
So interesting. Fascinating. Okay, I know we've just got a few minutes left, so I want to dive into one. Our patient population loves measuring things. So, is there, obviously we can measure these things in labs. Like, are there reasonable ways to measure this at home for people? Can they measure, are they adequately producing this compound? Like what you mentioned a minute ago. And then what are some really like specific things that people can do to optimize this?
Mm.
Some of them might feel a bit more obvious, but I know what people are kind of doing. And I know there's maybe some controversy around things like, red juices and beet juices and things like that. But let's dive into that, what we do about it for just a few minutes before we have to wrap this up.
Sure. Yeah, that was a question we tried to address about 15 years ago, because that was how do you know if you're nitric oxide deficient? Today we know the symptoms that manifest. But about 16 years ago, I developed a salivary test strip. Right, it's a salivary test. You apply some saliva to the end of this test. I filed patents, but I abandoned those patents years ago, and now many companies are selling those saliva test strips. But I abandoned them because they're really not that clinically. I shouldn't say that. There's no such thing as a false negative. So if you show low on that test strip, then pretty confident you're low in nitric oxide. The problem I ran into was there were so many false positives because people who have active oral infections would light up that test strip, and their interpretation was, "Oh, I'm making a lot of nitric oxide." And the real interpretation was, no, you got an active infection, and that's a response to a local immune response and not systemic nitric oxide production. So I think if you understand what these testers are not measuring nitric oxide, right? They're really measuring the presence or absence of nitrate-reducing bacteria. So I tell people you can use it. It's a good engagement tool, but it's really, you shouldn't rely on that.
Got it.
Because yeah, we have to rely on symptoms. And really, for me, there's no need to test because I believe that there's only two people in the world who need nitric oxide. There's the people who are sick and looking to get well. And there's the people who are healthy and don't want to get sick. So if you fall within one of those, you have to optimize your nitric oxide production. And now we know how to do that. And unfortunately, the challenge for me has been, these hundreds of companies out there trying to, sell you a bill of goods on a product that says they're nitric oxide, but they're either naive and ignorant on the science, or worse, they're intentionally deceiving the end consumer that trying to convince them it's a nitric oxide product. So that's the challenge I face with every day, is how do we differentiate our product technology based on 25 years of real science, being in the trenches, being in the research lab, understanding mechanism, and then developing safe and effective products.
Very cool. So, what are your top tips for, people to be doing with their lifestyle to optimize this, to optimize their own production, basically, and avoid depletion? And then should, in your opinion, both of those groups of people, which is essentially everyone, be supplementing with this kind of thing as well?
Well, look, it's very simple. The science is pretty complex, but sometimes the solution's simple. So you got to do two things: stop doing the things that disrupt it, and start doing the things that we know can activate it and stimulate it. And so again, that's, if you're using fluoride toothpaste, you have to stop. If you have fluoride in your drinking water or municipal water, you got to get a filtration system. If you're using mouthwash, you must stop. And if you're on antacids, you absolutely have to start weaning off antacids. Now you've released the brakes on the body's ability to promote and produce nitric oxide on its own. But we can activate this. Moderate physical exercise. I used to say 20 to 30 minutes of moderate physical exercise was sufficient. Now we know that, 3 to 5 minutes of high intensity interval training can improve nitric oxide production. Throw in some more green leafy vegetables. And then 20 to 30 minutes of sunlight today. Direct exposure to sunlight can release nitric oxide bound to metals, and UV frequency can release nitric oxide bound to cysteine thiols. And so diet, exercise, sunlight, and then when all else fails, we have products that do it for you. But sometimes it's really that simple.
And who do you think is a good, I mean, I know you can't be providing medical advice here, but just broad strokes, who do you think are good candidates to be supplementing with this kind of thing? This is going to be the question for most of the people
Yeah.
in listening to this specific podcast. This is the super interested group in biohacking and regenerative medicine and data.
Well, I think if you have any of the symptoms that we started discussing, what we have today on the market is called dietary supplements, and not intended to treat, prevent, cure any disease. But we're developing this technology in drug therapy for specific indications like heart disease, Alzheimer's, topical drug for diabetic ulcers. But look, if you have metabolic disease, if you have an unsafe elevation in blood pressure, if you have mild cognitive impairment or exercise intolerance, all the things we've talked about, then you absolutely have to supplement or restore nitric oxide production. So that's number one. And then two, there's people like me who are healthy and don't want to get sick. And I've been taking my product for, early forms of it for 20 years. And I take it not because I need it. I take it because I don't want to need it. Right. And so I want to always optimize my nitric oxide production. So you can take it as a reactive practice, or you can take it as a proactive, prophylactic approach, which is what I take.
And I'm looking at your website now, n101.com. So everybody check it out. Are these nitric oxide lozenges the product that you take,
Yeah.
if you don't mind sharing?
Yeah, this is
There you go.
our orally disintegrating tablet, and I'll just demonstrate how it works. But this is a little wafer. You just put it in your mouth and you let it dissolve. But as this lozenge is dissolving, it's releasing 20 to 30 parts per million nitric oxide gas. In fact, the same dose you would give in a critical care unit for premature babies with pulmonary hypertension, we're releasing a therapeutic amount of nitric oxide gas. So if your body can't make it, then we're providing it for you. And so I take the lozenge. We make a fermented beet powder for pre-workout called NO Beet. We make a topical line of products for skincare and beauty, a dual chamber serum, and it's an incredible product for skincare and beauty
Cool. You take those daily.
every day. I
Rad.
take it for
Yeah.
the
We've got a lot of people who, whether they have a family history, whether they've got maybe an ApoE4 SNP and they know they're at
same.
higher risk of dementia, a number of reasons, sometimes multiple that are like, what can I do now to optimize things in 20, 30 years, right? This
For
is
sure.
this is super, super common in our patient population. So they're going to be excited to
Yep.
hear this. So very cool. I want to be mindful of your time. I've learned a lot. I really appreciate it. My last question for you is, what about people? I know this can dilate blood vessels and can theoretically or can just drop blood pressure a little bit for people. Do you see that as a problem? Like, do you typically see this as a barrier? Especially like post COVID, I'm seeing this in some people. I'm not sure if it's from sodium wasting or autonomic dysfunction, but I'm seeing these low blood pressure issues. So is this something that, obviously people need to work with their direct physician and monitor these things, et cetera. It's not a completely benign thing. But do you have any general observations on this?
Yeah, that was a very important question that before I ever started thinking about productizing technology, is we did 24-hour ambulatory blood pressures on patients with high blood pressure, with normal blood pressure, with extremely low blood pressure. Severe hypothyroidism of blood pressures of, say, 90/60. And when we give the lozenge, if your blood pressure is not elevated, there's no drop in blood pressure. So even though I'm putting this lozenge in my mouth, my blood pressure typically runs 118/72, and there's no drop in blood pressure. And even in the people with really low blood pressure, when you take the lozenge, there's no further drop in blood pressure. So we don't see an unsafe drop in blood pressure. It's restorative by nature. And in fact, in our COVID study, we had patients that were on sometimes 18 to 20 different prescription medications, and we gave the lozenge on top of that. And the FDA required us to monitor them for the first hour to make sure there was no first dose effect and no unsafe drop in blood pressure. And even in patients with extreme polypharmacy, there was no unsafe drop in blood pressure. So the amounts that we're delivering through this technology is not sufficient to lead to unsafe drops in blood pressure. So it's extremely safe.
Very cool. I have typically a 90/60, so I'll jump on our Instagram stories, guys, and let you know. I'll check out
Rib.
Dr. Nathan's product, Dr. Bryan's product, and I'll let you guys know how it goes. But that's really cool to hear. This was super informative. I loved this interview. Thank you for teaching me. Thank you for being here. Check out his book. Check out his website in
Yeah, I'll give
101.
the shameless plug for my new book, The Secret of
Please
Nitric
do.
Oxide.
The Secret of
Yeah.
Nitric Oxide.
Now this really tells the story of nitric oxide, how it was discovered, what led to a Nobel Prize, and really chronicles my own personal journey of discovery in that. So I highly encourage you to read it. It's a bestseller on Amazon. It's working its way up the New York Times. So yeah, it's a great read, and I encourage everybody to read it. Not because I wrote it, but just because I think the information is so powerful.
Awesome. Thank you for being here.
Thank you, Ryan. Take care.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.